I feel, ladies and gentlemen, I feel very pleased to present our prospective study regarding early infundibulotomy and difficult ERCP. So I'm Dr. Raied Alhameedi, which I'm working with Dr. Stéphane Claire on University Hospital of Rouen. First of all, difficult common bile duct cannulation. It's a frequent problem, which represents 10 to 20%. This difficult cannulation could be defined by cannulation which take more time which needed, or repeated attempt of cannulation. It's a condition where there is more complication. There is several techniques being used for this problem, but the complication rates seem to be higher in this group. There is, as described before, there is several techniques being used for this type of problem. Pre-cut sphincterotomy, starting from the papilla, infundibulotomy, which is also called fistulotomy, suprapapillaire, or pre-cut over pancreatic stent, or transpancreatic sphincterotomy. When we see there is the very frequent pre-cut procedure, needle knife procedure, pre-cut sphincterotomy, starting from the papilla, or needle knife fistulotomy or infundibulotomy, starting above sphincterotomy, starting from the papilla, or needle knife fistulotomy or infundibulotomy, starting above the papilla on the infundibulum. We consider this technique, there is no additional risk for pancreatic duct trauma. Several studies that shows that risk of pancreatitis post ERCP, it's higher with pre-cut papillotomy or difficult cannulation. This is a study which made by our hospital, which showed that there is a significant risk of posterior ERCP pancreatitis if it is done with a pre-cut papillotomy, or the duration of the cannulation more than 15 minutes. So our aim of this study to assess prospectively whether the repeated attempt or the duration of conventional sphincterotomy or the infundibulotomy itself are the origin of the post-ERCP complication. At the same time, to evaluate the efficacy of early infundibulotomy. So we had this prospective study, including all the patients underwent ERCP between January 2013 and October 2013. We exclude all the patients with active pancreatitis before the procedure. We're collecting the data about their age, their gender, the procedure indication. Biological data, we controlled the serum lipase 4 hours and 24 hours after the procedure. Endoscopic data, the need of infundibulotomy, if there is a stone extraction, if there is a stent insertion, if there is a sphincterotomy large or minimum, the duration to obtain the bile duct cannulation, and the duration of the repeated attempt before infundibulotomy. The timing of the infundibulotomy, it's determined during ERCP procedure, depending on the operational factors. It could be, we divide it into three groups, less than 5 minutes, between 5 and 15, and equal or more than 15 minutes. The factor that we used for early or immediate infundibulotomy, if there is bulging papilla, impact common bile duct stone, large infundibulum, normal coagulation profile, and common bile duct dilatation. On the other hand, delayed infundibulotomy, we use it with minimum 10 minutes of attempt if there is very small papilla, pre-diverticular or papilla in intra-diverticular position, small or non-visible infundibulum, and if there is abnormal coagulation profile, that we use only if there is an urgent ERCP patient with septic cholangitis or other urgent indication. The technique that we use, it's used by the experts endoscopic in this technique. Starting point midway between the outer surface of the infundibulum and the papillary sphincter with needle knife Boston material. And we do the incision at this point from above to downward from 12 to 6 o'clock until we reach the common bile duct. We have 113 patient. From above to downward from 12 to 6 o'clock until we reach the common bile duct. We have 113 patients, 43 of them with tumoral common bile duct obstruction, stone in 70 patients. A total of 80 patients with cannulation was obtained by conventional procedure, which equals 70.8%. And 33 patients, infundibulotomy was done with effective cannulation in 30/13, which equal 90%. The overall success of cannulation, it was about 96%. Technical failure in 5 patients, 3 of them without attempt infundibulotomy. We had 13 cases of post ERCP pancreatitis, 8 of them with infundibulotomy. Was done after 15 minutes. This pancreatitis, it includes the very minimum pancreatitis, which could be a pancreatitis with no radiological sign with 3 days of hospitalization. 20 patients, the cannulation was lasted more than 15 minutes. 11 of them have pancreatitis, which equal 50%. There was no significant correlation between the occurrence of post-ERCP pancreatitis and common bile. There was a significant correlation between the post-ERCP pancreatitis and the cannulation more than 15 minutes. We didn't observe any post-ERCP pancreatitis in the patient with early infundibulotomy, with the attempt was lasting less than 15 minutes.